Assalamu alaikum everyone. I am Dr. Amara Kaleem, Senior Registrar Neonatology, on behalf of Department of Neonatology, University of Child Health Sciences and Children's Hospital Lahore. I warmly welcome you to the second scientific session of Neocloakium 2026. It is a great honor to request the presence of Major General Zishan Ahmed on the stage, a pioneer in neonatology who also laid the foundation for specialized neonatal care within the military healthcare system. He is teacher of teachers and has mentored generations of neonatologists and pediatricians, currently serving as advisor in pediatrics and military hospital Rawalpindi and Pak Emirates Military Hospital. I also respectfully request Professor Tahir Javed for his presence on stage. He is a distinguished pediatrician and academic leader, deeply involved in training and education through CPSP frameworks and Pakistan Pediatric Association Neonatology Program Facilitator. He has lasting contributions to the neonatal care in Pakistan. Now I invite Dr. Kaleem Akhtar Malli to the stage. He is renowned consultant pediatrician and neonatologist, currently serving as General Secretary of Pakistan Pediatric Association Punjab. He is widely recognized nationwide for his contribution as master trainer in neonatal and pediatric education. I would also invite Professor Saima Ali to please come on the stage. She is Professor of Pediatrics and Head of Department at Peshawar Medical College and former convener, Neonatology Group, Khyber Pakhtunkhwa. Our chief guest for today's session is Professor Tipu Sultan. He is Medical Director and Professor of Neurology at University of Child Health Sciences and Children's Hospital Lahore. Now I would request our chairpersons to start the session kindly. Thank you.
Bismillahirrahmanirrahim. I feel very honored and privileged to be here at this very august gathering. I'm grateful to the neonatal academia of both Pakistan and overseas to grace this occasion. And so we are going to be treated to a number of talks by a galaxy of senior consultants. So our first speaker is Professor Junaid Muhib Khan. He is the Director of Medical Education and Senior Consultant Neonatology at SSMC Abu Dhabi, UAE. He is a Professor of Pediatrics at Gulf Medical University and Professor of Pediatrics at Khalifa University. And he is an American Board Certified Pediatrician and Neonatologist. So I would request Professor Junaid.
Thank you very much, Zishan. Thank you for inviting always Professor Farah and her team, obviously my friend, my brother Irfan, and obviously my seniors all sitting there, the chief patron, Professor Haq. So this is, जो भी ये सामने की सीटों पे बैठे हैं उनके लिए ये टॉक नहीं है, वो दोबारा से चाय पीने जा सकते हैं. This is the talk I am talking about for my junior colleagues. And if you know the word or abbreviation of KISS, keep it simple. I will not say stupid, lekin I will say keep it simple and very simple. So it's a very simple talk. We will go through the fragile bone in preterm infants, a practical look to it. So I have to disclose that I have nothing to disclose. And very simple learning objectives: to recognize the risk factors, to define the clinical evaluation, and to discuss the management. तो आप सबके पास pen and paper होना चाहिए, and then we will go from there. So we will go by the cases. I don't want to know that what you people don't know. I want to know what you know. So just see those cases and write it down, that what you answer. 29 weekers, 1.1 kilogram, 4 weeks old, exclusive breast milk, ALP, alkaline phosphate, is 820, phosphorus is 3.8. So is this a metabolic bone disease or osteopenia of prematurity? What you will do next? This is the real case. It is 29 weeker, day 58, birth weight is less for 29 weeker, 749. Past medical history, he has all the neonatology diseases he can. X-ray, I don't know if you can see from there, but it is severe metabolic bone disease. Third case, so what we should do with that case also. Third case, 27-week, 850 gram on diuretics, prolonged ventilation, ALP is around 1100 and X-ray shows osteopenia. So what you will do in your unit. And the last case is 32 weeks, 1.4 kilogram, discharged on exclusive breast milk, readmitted at 8 weeks of age, and alkaline phosphatase is 950 with metaphysical changes. So these are the 4-5 things which we have to know that what we can do in practically. Definition is very difficult because I will tell you what Professor Huck presented yesterday. There are a lot of things that we don't have a clear definition. These definitions are like a dictionary definition, but not the consensus medically. So it is metabolic bone disease, rickets or osteopathy of prematurity, whatever you said. The bone mineral contents are not as much as the gestational age of a baby, and decrease BMC occur mainly as a result of calcium and phosphorus. So 3 things you have to remember: reduced minerals lead to fragile bones and associated with skeletal abnormalities. Because we don't know and lack of consensus of definition, the incidence we cannot calculate. So estimate is from 15-16% to 40%, and ELBW is more maybe. Typically present as around 6 to 16 weeks. Biochemical changes are there, we will discuss, and there are radiographic changes. In our culture, in Pakistani context, why it matters? High preterm birth rate. Yesterday, somebody is saying that it is around 20%, somebody is saying 18. What I look when I'm preparing this, it is around 23 to 24%, but it's not very robust or very accurate data. Limited access to human milk fortifier, variable TPN quality across the NICU. Don't run behind TPN. I will tell you what you should do. Later or no post-discharge follow-up, and high risk of undetected metabolic bone disease. So if you can see in a graphic form, ELBW is 50%, VLBW is 40%, preterm infant in total is about 30%, and 40% is the breastfed preterm. So these are just a rough number to give you the severity of this illness. It's inversely proportional to the gestational age. Now, a little bit of physiology. Bone mineralization occur primarily in 3rd trimester. So as you can see here, the gestational weeks and the mineralization is almost going up around 30 weeks onwards. So 32, 34 weeks and then shoot up. Now, premature baby don't have this luxury because they born early. So the calcium, the phosphorus, and all this, they can be deficient in it. And the mineralization is not that great. Simple thing, gestational week and the calcium content, it is like on the lower side up to 30, 32 weeks and then goes up. So bone mineralization, like many other things, happening at the 3rd trimester. So fetal mineral accretion means absorption in the bone is required the 3rd trimester. So if you can see here that at 28 to 38 weeks, the weight increased by 3 times, the calcium content increased at a rate of 120 to 150 milligram per kg per deciliter, and phosphorus also increased by 75 to 85 milligram per kg per deciliter. So these are the main things what we are missing in the premature infants. Now the fetal mineral transport, how it is happened. So there are some major minerals, calcium, phosphorus, magnesium and iron. This is the maternal blood, this is the fetal blood, this is the placenta, this is the intervillous space, this is the syncytial trophoblast, and this is the fetal endothelial cell. It crosses nicely and it reaches through the endothelial cells, it reaches to the fetal blood. Simple. So calcium, phosphorus, magnesium for bone, for hematopoiesis is iron. They are all coenzymes and cofactors. There is mild difference between cofactors and coenzymes. So they help in neural development, and then they have the muscle function. Old book of physiology predicts very nicely. The big arrow, fat arrow, means lot of calcium going towards fetus, and of course there's a small amount going towards the placenta also. So lot of calcium going into the bone. The circulation, the absorption of the gut and the kidney is not that high in this thing. So placenta delivers minerals, bone receive it, kidney and gut contribute very little in prenatally. Then baby delivered, now the postnatal changes, the estrogen goes down because of the calcium deficient, the thyroid hormone, parathyroid hormone goes up. Loss in utero mechanical stimulation and loss of mineral contents of human milk. So these are the things what we expected in those premature babies. High requirement, limited intake, and PN limitations. So TPN has solubility limits. So that's why feed the baby. Do not interrupt the feeding. Okay? I mean, abdominal distension or thodi si vomiting, thodi si regurgitation, do not stop feeds. Okay? Especially if the mother's milk is available, because TPN has a lot of other problems with that. Come back to the basic, because somebody told me that if mother is healthy, having good calcium, so why to give vitamin D to all babies as recommended by AAP? Vitamin D is recommended because of this. So you all know, I don't have to go through it, that calcitrol, 1,2,5-hydroxy vitamin D3 required by the gut to increase the calcium and phosphorus absorption. So whatever the amount of calcium in your food, whatever the amount of calcium in your mother's milk, if this is not there, the calcium and phosphorus is not reabsorbed. So that's why you have to give vitamin D. So calcium metabolism and the regulation is a very tight control of it because of the parathyroid hormone, and it has a clinical significance of it. We will talk about it. So how it works? This one we already discussed, the vitamin D. Vitamin D increase the absorption of calcium. Let's say the kidney is losses, the bone resorption happening, and calcium goes down. It triggers the parathyroid hormone. Parathyroid hormone goes up and then start stimulating the 1,2,5-hydroxy to increase the absorption. So the plasma calcium will go up. So that's a simple way to understand the metabolism of calcium and phosphorus. Once again, parathyroid hormone, it is the thyroid, there are the 4 parathyroid glands. If it is decreased calcium, increased parathyroid, increased calcium and phosphorus in secretion in blood, increased absorption. So that's how it is worked. So somebody in the evening yesterday talking about ionized calcium. How many of you think ionized calcium is important in that bone diseases? Anybody? Raise hand. Okay, we will ask you. Ionized calcium is important, but it is a different function. Neuromuscular function, cardiac function, hormonal regulation. In osteopenia and metabolic bone disease, ionized calcium is usually normal. So it is not the indicator of this topic what we are talking about. So why it is, as I said, because it is tightly regulated by parathyroid and vitamin D, and calcium is mobilized from bone to keep the serum level normal. So don't chase ionized calcium in this particular condition which we are talking about. Another thing, if the ionized calcium is low, what it suggests? Inadequate calcium intake first, severe vitamin D deficiency, hypoparathyroid or magnesium deficiency, and acute illness, sepsis, acidosis, alkalosis. So this is more about the acute metabolic instability rather than the metabolic disease, metabolic bone disease. So differentiated, I always said whenever you do any test, whenever you do things, you know how to interpret it. So these are the calcium. It's clear, very simple way we think. Now the phosphorus. Main with this problem, which we call osteopenia, prematurity, or metabolic bone disease, phosphorus deficiency is usually the primary driver of the bone, poor bone mineralization. So why? Because it helps in hydroxyapatite crystals, form the mineral matrix, and directly impairs bone mineralization when insufficient. So phosphorus is the great marker for this disease, and these are some clinical significance. Not only that, phosphorus is the earliest marker of diagnosing this disease, appears 7 to 14 days after birth. These are the normal values, okay, which written in the books. Hypophosphatasia is 1.8 millimole to milligram per deciliter, multiply by 3.1 millimole for phosphorus, multiply by 4 for calcium. So you can convert either way. So these are the thing about that. To sum up all these things, if you can see the calcium deficiency, phosphorus deficiency, and this is the absorption, and how it is work around it, that if any of those deficiency, the PTH goes up, the PTH goes down, and then the mineralization of the growth plates and bone, and then we have a metabolic bone disease. Come to the risk factors. These are the few risk factors, but there are many more risk factors. So I don't have to go. It's just published in AAP clinical report, okay, 2022. So prematurity, what you call the less weight, long-term parental nutrition, and all of those. But other than that, I notice here also in Pakistan and many other places in the world that we are overusing the medicines. And look at the effect of those medicines, especially the corticosteroids, very commonly used, loop diuretics, every baby is on loop diuretics, phenobarb, TPN, theophylline, anticoagulants. Everything has its effect. So please, if you need it, use it. If you don't need it, it's not like that you continue for a longer period of a time. Three main medicines which we are using in NICU, diuretics, corticosteroids, methylxanthines, caffeine, contribute to inadequate bone mineralization. Now the irony of it, caffeine now are studied that if you use for a longer period of a time, it has a very beneficial effect. And the data is, himself, Eric, is going to present in March in our conference. But what about this? So we have to see that how the data suggests. Now, if you see this published in 2024, if you give diuretics for 2 weeks, the adjusted odd ratio is 2.53, and the p-value is significant. And look at the confidence interval; it is all going towards the right. So it is very significant. Same with the TPN, more than 28 days, and postnatal steroid, about the same thing that we are getting. So these medications has effect on that. That's the comorbidities, BPD, NEC, cholestatic liver disease, prolonged immobilization, sepsis, everything is there. So these are the changes of osteopenia, biochemical phosphate deficiency, hyperphosphatasia, and calcium deficiencies which we have. And if you can see the Kaplan-Meier graph that if you have the MBD, the length of stay increase, the cumulative score of the mortality is increased as compared to this. Statistically, it is significant. So we have to be very careful when we have dealing with 32, 34, 33, or 31 weeks, or maybe lesser. The major questions that what is alkaline phosphatase and why we have to check. So simple answer, alkaline phosphatase is a marker of bone turnover that indicate increased bone cellular activity. Physiologically increase in first week of the life, sustained elevation indicates bone pathology. You just have to remember that. It's enough. These are the thresholds. 7 to 750 means there is already osteopenia. 800 to 900 highly suggestive of metabolic bone disease. 500 and below we are okay. I will show you some screening pathway what we are using. So the clinical significance, if it is combined with the low phosphorus, it is more assured that the baby has a disease. Persistent elevation require intervention, and we have to monitor in the chronic babies. Other markers we all discuss about phosphorus, calcium, 125 hydroxy. If you have in your lab two phosphorus and alkaline phosphatase, it is more than enough to do the test. You don't need it anything. The other thing you should know about tubular reabsorption of phosphorus, which you can easily do it in the urine and the serum. What is the formula? 1 minus urine phosphate divided by urine creatinine times plasma creatinine divided by plasma phosphate times 100. So what is the meaning of that? You have to obtain the urine and the serum same time. High TRP means low urinary phosphate, low TRP means increased urinary phosphate. So what is the meaning of that? So I just make a table to what is how you interpret it. If TRP is high, the kidneys are conserving the phosphorus. Serum phosphate can be the low or low normal. You give the it's a nutritional deficiency. That's how it is important to interpret the results of your test. Because if you here give the, treating the renal loss or parathyroid, it will not affect. And vice versa. If you give the loads of phosphorus here, it will not affect because here, wasting pH and the serum phosphate low. So you need, to correct the parathyroid hormone or the renal loss. Here you correct the deficiency of the phosphorus by giving the nutritional supplements. So that's how it is. You all know what the potential consequences of that. There are a lot of old studies, they talk about fractures. This is rachitic respiratory distress. So sometime in chronic BPD, it has happened in us, I noticed myself, okay. So sorry about that, it is mine. Okay, I just declined. So anyway, so it says that baby has a distress, and let's say baby is on non-invasive but confirmed BPD. And the people is starting thinking of sepsis, people is starting thinking of something else, or doing the X-rays. But sometimes the bone mineralization and bone things are not that great. So the baby has a difficulty in breathing because of the bone deficiency as compared to the lung or some other pathology. So we have to be very careful in these babies. Then head flattening like this, dolichocephalic, and potential long-term effect on the growth. Okay. Clinical significance, so in a nutshell, very important: fractures, respiratory complications, poor growth as a short-term, long-term is the long-lasting effect of the skeletal and the growth, rickets can happen, and early osteoporosis. Radiographic findings are change happened very late when already the disease occurs. So if you can see here, the fraying, when you cut something and uske dhage nikal aate hain, it looks like that. But to make it more, this is the bookish picture. Look at how beautiful it is. White, it is thick cortex, and the white line is there. Then look at this. It is getting thinning, and this is the white line. This white line is gone. And look at this. This is fraying and very thin cortex. And due to that, this is thin cortex, cupping of the metaphysis, and there is a fracture. So these are the consequences and stages of the radiological appearance. Screening, again, there is no consensus. UK has their own and US has its own, but you choose your way to screening those things. This is our protocol. Any baby less than 15, less than 32, TPN for more than 4 weeks, course of diuretic or steroids, we do weekly bone profile of calcium, phosphorus, alkaline phosphatase. If the phosphorus, is that, and ALP is more than 500, we do the TRP and then decide accordingly. But again, this is our protocol, but you can modify it according to your needs. Other things you can do, we already discussed about. Just for information, this is very expensive, DEXA screening. It is also not available in Abu Dhabi, but we are doing in Rochester, Mayo. It is very highly cost, but it is very definitive diagnosis. This is the new term, the quantitative ultrasound. This is just for information I am giving you. They measure the speed of sound through the bone. The greater the speed of sound through the bone, the higher the chances that the baby has a healthy bone. But it is very new thing coming up. So this is the protocol we are using, that if the baby has 500 or below ALP, don't ask me from that number come. This is the number come from the heaven, and we are following it. Vitamin D, if the weeks of life, if the vitamin D level is this, then we increase that much. If this, we increase that much, and so on and so forth. So that's how we are monitoring our babies. I will give all this talk to all of you. Just this is the same thing which we are now. This is the problem, and I'm again saying what Professor Huff said yesterday. So I went personally, they invite me to for the premature enteral feeding in May 2025 in Finland, in Espegan. And look at this. This is published in New Reviews, so it is a very reputable, respected journal for neonatology. How much difference in the recommendation? I don't know. We are using our AAP because we are under AAP. So we are using the AAP, the 150 to 220 milligram, if it is on peripheral TPN, that much, if it's central, that much, if it's formula, and all those. There are a lot of recommendation. I think this is, I will show you one quality project you can all do and decide accordingly. The calcium also is the difference in difference. So if you are giving unfortified milk, that's the amount of the calcium and phosphorus and vitamin. You have to fortify it, that much you get. Then preterm formula is that much, and transitional formula is that much. It's 2:1 ratio we are giving. There's the old study by Professor Nina Modi that you don't have to fortify the milk, which many of us is not agree because of not only that. If you ask in your unit that why we are fortifying the human milk, the most common answer you get to gain weight. Okay? The more important answer to provide adequate protein, micro and macronutrients. So that's why we have to provide. Calcium phosphorus supplementation recommendation, these are all over the place. This is one of the things from our formulary, we are using it. So prevention and treatment of osteopenia, optimizing nutrition, limiting use of certain medication, and you can provide that. Practical prevention, early minimal enteral feeding without as much as interruption for our country. Human milk fortifier, use when available. If it is not, use preterm. I will give you the table that how to use both together. Do not stop the breastfeeding and start formula. I will show you in a minute. Routine ALP plus phosphorus screening and clear discharge feeding advices. So if you have a problem, consider calcium supplementation if your markers are these ones. Elevated ALP, PTH is high, low serum phosphate. If give the phosphorus, if elevated ALP, low PTH, and low serum with high TRP, use the phosphorus. We are using 400 international unit in all the babies of vitamin D. So these are our pathway, which I already discussed. I don't have to go through it. I will give it, send it to all of you. What is the core thing? That mimic in utero mineral accretion early and continuously. How you mimic it? Just give the breast milk. I mean, we cannot emphasize more than that. Okay, for phosphorus, which is the main thing in the metabolic bone disease, you need probiotics. It is in the milk. GOS and FOS, galacto-oligosaccharide, fructose, it is in the breast milk. Omega-3 fatty acid, whey and casein proteins. Vitamin D is not, so that's why we are supplemented. So factor that enhance phosphorus so you can mimic it. Why we are using multivitamins? Because of this. Zinc, essential for osteoblast activity. Potassium, buffer acid loss and reduce calcium. Vitamin A, regulate osteoblasts and osteoclast differentiation. Vitamin K, required for osteocalcin carboxylation. Vitamin C, collagen. Collagen is the main ingredient of bone. Probiotic, prebiotics, and so it is the multi-nutrient factor you should use it. Now I have less than a minute, but I lost 2 minutes, so I will take only 2 minutes. So this is the first case. Yes, it is the osteopenia of prematurity. What is the cause? Anybody? What is the cause in this case? Exclusive breast milk. Excellent. How you manage? Huh? You give the phosphorus first and supplement the mother's milk. Okay? Got it? Teaching point. Stable babies still need screening. Next case. You remember that I showed you NEC, everything, the second case. These are his labs. ALP high, phosphorus is low, calcium is near normal, PTH is low, TRP is very high. What you will give? Excellent. Phosphorus. Optimize nutrition first, give phosphorus. Third case, easy case, 850 furosemide, ALP, X ratio, osteopenia. What you should do? Anybody? What is the risk factor here other than prematurity? Furosemide and ventilation. Thank you. Everybody wake up during my talk. Thanks a lot. So ALP is very high. What you should do? Again, X-ray is late review, and you have to increase vitamin D in this case. Okay? Last but not the least, 32 weeks, 1.4 kilogram, unfortified breast milk, readmitted. What you will do? Why it has happened? Because of unfortified. So you have to have a good discharge planning. Okay? This is the case I give you as a homework. You answer it and send it email to Professor R, and he will mark you. Okay? So that's the thing. Okay, you can take a photograph, but anyway, I will send you that this is the case. 29-weeker female with short bowel because of the surgical neck, TPN dependence, demineralization and multiple fracture, labs, high parathyroid, low phosphorus. How you manage this kid? This is a very common, not very common, but common thing in our world. This is very important. Do not stop breastfeeding, please. Do this, okay? If you have 6 feeds of breast milk, add 2 feeds of mature discharge, that's what you get. 5 feeds, 3 feeds of premature at discharge, you will get. If 6 feeds and premature formula, 30 kilocal time 2 feeds, that much you get. And that's how you discharge the baby. If it is in formula, then you don't have to do anything. But I am talking about if the baby on the mother's milk, please do not stop the mother's milk. You add 2-3 feeds according to your level of phosphorus and calcium in with the thing. For all the young people, this is a very good quality improvement project. First, make a standardized protocol. These are the metrics you have to use. Early detection rate, time of intervention, incidence of fractures in your unit, and long-term bone health. How to do it? Plan. Identify at-risk infant, implement monitoring system, review the biochemical markers, and adjust the protocol. It's an excellent project. It is, you can do it very easily. If you need my help, I am more than welcome. So the key thing, prevention is paramount, proactive screening, nutritional strategies, and monitoring of intervention. For us in Pakistan, the key message is MBDs commonly happen and under-recognized. Most cases are preventable. Screening is low cost and high yield, and nutrition matters more than any MRI or X-ray and imaging. These are my reference, and thanks a lot. And if you have any question, I again refer towards Professor Haq. Thank you very much.
Thank you so much, Professor Junaid. We'll be having the question and answer sessions once all the presentations are done with. And I'll now request Professor Tahir to announce the next speaker.